God.
Hey everyone, we're back. Sorry I missed the morning lectures. I heard that Dr. Langer did a great job, and I obviously caught most of Dr. Patel's. It looked great. So this is one of the sessions that I'm very, very, very excited about. Basically, we were fortunate enough to get the Zucker School of Medicine to contribute over the next 8 weeks with this lecture series, and they're basically going to give advice on getting into medical school, talking a little bit about dealing with medical school. And you know what, actually, I'll let Dr. Willey go ahead and explain what they're going to do and how this is going to work. We're pleased to have her. We're excited. This will be the last lecture of the day. And so we'll meet you guys tomorrow. Tomorrow, we've got a good day ahead of us. We've got the first of the special summer seminar series where we've got one of the ER docs talking about his experience during the COVID chaos. And then we've got the first virtual neuro-onc tumor conference, and I'm actually going to deliver that. There's a good chance we'll be doing a live surgery. We're going to cover meningiomas, and we'll be probably in the OR with Dr. Bookvar and myself. So definitely stay tuned for that. And then at 11 o'clock tomorrow, we have the first of the cardiology lectures. So departing neurosurgery for a little bit, but that's a great series for people who have other interests as well. So anyway, Dr. Willey, thank you so much. I'm going to leave it to you. Enjoy.
Okay, thank you. I want to thank the Lenox Hill team for inviting me, and this sounds really exciting. Maybe if I had time, I would log on tomorrow. Unfortunately, I have other things. So as Dr. D'Amico said, this is the first in a series of Monday sessions where folks from my department, the Department of Science Education at the Donald and Barbara Zucker School of Medicine, will be talking to you. And what the idea is that we're going to introduce you a little bit to careers in medicine, not just medical school. That's kind of what we're going to talk about today. But also how to get into medical school, how to be a medical student. And even if you're interested in another career, this is always kind of good life advice as well. So without further ado, what I want to do is I want to make it clear that this is, I kind of understand that you've been sitting for a couple of hours. So I want to make this a little bit more interactive. So when I'm asking questions, if you guys could hop on the chat, we're not going to wait until the end of the session for questions. I'm going to actually ask you questions and you're going to give me answers. So I'm going to be looking at those chat answers to keep the discussion going. And I need, it looks like you guys are a pretty vibrant group. I saw lots of questions with the last presentation. So I look forward to having you guys participate. So what we're going to do is we're going to be looking at biomedical careers, but also I think at the same time, we're going to be looking at how it really takes a lot of teamwork in order to advance patient care. We're going to be looking at an international case study, and I thought in the age of COVID, what better kind of case study could we use than an epidemic? So to start, so I need some help here because I can't see the chat.
It should pop if you scroll up to the top or bottom of your
Yeah,
screen.
I see the top.
Yeah.
So if you guys could start just, is it under Q&A? Where's more?
It's just under chat.
Oh, chat. Okay, I see it. Okay, so if you guys, sorry, I'm being technically inept. Okay, so if you guys could just think of epidemics that you've heard of and COVID doesn't count. How's that? So epidemics that you might have heard of in the past. Woo, look at you guys go. Holy moly. Okay, I see Ebola, MERS, Spanish flu, Ebola, AIDS, good. Dengue, not so much, well, small epidemics. Cholera, okay. So let's see. H1N1, Spanish flu. Nice. All right, bubonic plague, that's a big one, bubonic plague. So we're gonna explore epidemics today a little bit. So what's interesting is, let me just keep looking. What's super interesting to me is that nobody put this one up that I can see. Anybody, what's this? Smallpox, yep. Smallpox is a horrible, horrible condition. You can see this poor young gentleman is completely covered in pustules. And exactly, poor kid, I agree with Molly. And why don't we see smallpox anymore? Anybody? Vaccine, right. So this is a disease that was eradicated, and it was eradicated, Edward Jenner, okay, cool. So it was eradicated, all right, you guys are too smart for me. Does anybody know the year? So if you actually, you did an anagram there, 1997. You're getting there. 1978, yeah, close, okay. 1979. So in the 70s, it was eradicated. So smallpox, there's two kinds of smallpox. One, first, actually, let me back up and introduce my background. So I'm chair of the science education department at the Zucker School of Medicine, but I'm also a microbiologist, and I teach infectious disease and microbiology to second-year medical students. So, so I can talk about epidemics all day. So, so smallpox, there's actually, if smallpox has been eradicated, why hasn't chickenpox? So Lilly is on the right track with it's a different kind of virus. So smallpox is a very, smallpox and chickenpox, even though they're both called pox, are completely different viruses. They're called, does anybody know why they're called pox? What does pox refer to? Pimples, pustules, lesions, spots, yeah, boy, bumps, rash. This is great. So yes, the pox is the actual condition of getting these kinds of pustules. And you can see that this unfortunate child is covered with pustules that are all what we would call the same generation. If you were to look at them, they would all look exactly more or less exactly the same. They all come out at the same time, and they age at the same rate. Whereas smallpox is like this more progressive. First of all, it's caused by a completely different virus, is not nearly as fatal. It's hardly ever fatal. If you were to try to pop one, what would come out? Not just like serous clear fluid, like a crust. So in any way, so chickenpox has more of a progressive development of pustules. So they were named pox back, so we didn't understand what viruses were until the very beginning of the 20th century and then some. So these diseases are oftentimes named based on the symptoms or the signs, what you can see, how the patient feels. They're not named after the particular organism or virus that causes them. So smallpox, we don't see smallpox anymore because there was an eradication. I'm assuming this hurts. Yes, it does hurt a lot. So we don't see smallpox anymore because there was an eradication campaign. And the eradication campaign actually has a link to New York. So what happened in the 1940s was there was actually a smallpox, well, it was small because it was contained, epidemic in Brooklyn of all places. And what happened in Brooklyn was there were a few people that were diagnosed, and immediately the Department of Health realized, holy cow, if we don't contain this, you know, there weren't 8 million people then, probably about 5 million or 6 million, but that's still a lot of people at risk. And so what they did was they looked at the epicenter of where these few people lived, and they drew concentric rings around them and wouldn't let anybody out of those rings, and vaccinated everybody in those rings. And that's called the ring strategy. And in fact, that's how smallpox was eradicated. A vaccine was developed, and this was back in the 60s. So a lot of young, idealistic, what used to be called hippies, joined this crusade. They were literally called vaccine warriors. And they rode motorcycles all over the world, literally all over Africa, all over India, all over Asia, and went from town to town and asked who has smallpox. And whoever had smallpox, they figured out who had contact with that person, and they vaccinated all those people. the reason they used this ring strategy was because there just wasn't enough vaccine to inoculate every single person on Earth. So they had to find out who needed to be inoculated. Now, you've all been following the news, I'm sure, about COVID, and you understand that they're developing a vaccine. A vaccine is being, well, 150 different vaccines actually are being developed for COVID. One of the big differences between smallpox and COVID, besides the fact that smallpox has about a 30% mortality rate, and COVID is, somewhere in the order of half to 1-ish%, is that smallpox is only transmitted when the person is symptomatic. And when a person is symptomatic, they look like this. So it's very clear who has the disease, who's communicable, who can transmit it, who needs a vaccine, anybody in contact with a patient like this. The other reason we were able to eradicate smallpox is because it doesn't live in an animal. There's no natural host for smallpox besides people. So that if you can inoculate all people, you can break the chain of infection. In other words, it can't be transmitted from person to person. So if we go to the next slide, we can see one of my heroes. This is Ali Maslin, and he is the last person to die of smallpox. He also was a vaccine warrior. He was obviously vaccinated against smallpox, but for some minority of people, for every vaccine that's out there, they don't respond. And that the sort of slang is the vaccine didn't take. So you can imagine, here's this guy, he thinks he's completely protected because he had the vaccine, and he's going out and he's vaccinating people. So of course, he developed smallpox. Now, when he developed smallpox, he was the last person to develop smallpox, last known case of smallpox. And he, of course, got a great treatment. Everybody was very worried about him. He survived. He died of natural causes in 2013. But he was one of the vaccine warriors. He was from Somalia. About what percent does the vaccine not take? Typically less than 5%, so pretty small. So let's look at some of these questions. Is it possible to completely eradicate a virus, or will there still be some of it present in the areas of the world? There is in fact some smallpox left in the world. Does anybody know where it is? Anybody? CDC, yep. CDC and in Russia. So yes, I am aware that all smallpox is located in a lab at the CDC and ATL in Russia. Thank you, Tamara. That's exactly right. And it's a big ethical debate. Should we get rid of it? Should we take that vaccine and put it in an autoclave like a giant pressure cooker and kill it? Or should we leave it? So far nobody's decided to kill it off. Okay, so what other, can you guys think about some of the other epidemics that have occurred in history? Yellow fever, diphtheria, polio, cholera, flu, Spanish flu. Okay, Zika, great. All right, so let's look at some of these. So there's our four. So does anybody know what these are? Polio, iron lungs, yes. So this, what do we use now instead of iron lungs? Did he survive, this child? No, this child did not survive. Ventilators, yes. So this picture, anybody want to guess when this picture was taken? 50s, yes, in the 1950s. So in the 1950s in the US, every summer for about 4 or 5 years, there were intense polio outbreaks. Not in every community, but in many communities. And swimming pools would be closed. People would be afraid to go out. Whereas smallpox is transmitted the same way as chickenpox through respiration, but polio, does anybody know how polio is transmitted? don't tell. Yes, it's an enterovirus. So what does that mean? Yeah, fecal oral. So fecal oral, or the more you know, if you want to be, if you're a little shy about the F word, you can say FO. So fecal oral. So it's an enterovirus. So the thing that's interesting about polio is that you get it by ingesting contaminated food or water, which is why the swimming pools were closed. And only in 1 or less than 1% of people who get polio or who ingest the virus wind up having this paralytic disease. And the reason people would wind up in these iron lungs is it would paralyze their diaphragm, so they could no longer, they would otherwise die of respiratory arrest. And so these iron lungs actually, you know, had an apparatus inside that made the diaphragm, that basically did the work of the diaphragm for the individual. Yes, former President FDR had polio. Now, he was a really interesting case because most people who got polio were kids, because adults had some residual immunity, or most, back in the 50s, many adults had some kind of immunity, but FDR got it in his 30s, in the prime of his career. And yes, he never admitted that he never would be, he was very careful in his public image not to show that he was disabled, which is a whole nother story. Rickets is actually a vitamin deficiency, so something completely different. Okay, so, whoops, no, I'm not. Another epidemic is yellow fever. So yellow fever is caused by a mosquito. This is the most, this is a giant yellow fever mosquito. So it's caused by the same mosquito that transmits dengue, Zika. And we have a really good vaccine for yellow fever, but right now the vaccine is actually in short supply. There are still currently outbreaks of yellow fever, particularly in tropical areas. Yellow fever is a really kind of horrible disease. It causes a lot of internal bleeding. People, the sort of classic symptom is people throwing up what's called coffee grounds. And that's because their stomach, they've been bleeding into their stomach, and the blood is old and it coagulates because of the acidity, so it looks like coffee grounds when it's vomited. It's a really horrible disease. There was actually a yellow fever epidemic during the Constitutional Convention in Philadelphia, and people didn't know that it was caused by mosquitoes. And just like today, all the rich people left, went into the countryside. Poor people stayed. And people were told to leave their windows open because people thought that the fresh air was, would help you get sick from getting sick. So obviously that was kind of bad advice. Whoops, kind of bad advice, because you obviously are letting all the mosquitoes in. This picture is taken from the 1918 Spanish influenza outbreak. Does anybody know why it's called? Yes, sounds like drinking it. Yeah, well, see how far we've come. Does anybody know why it was called? They were the first to report. You're answering my question. Yes. So what happened was, when did this, in 1918, what else was going on in 1918? World War I, exactly. So in 1918, Spain was not in World War I. And so they were actually publishing and disseminating the information about this flu. And so because they were publishing the most about it, yes, Spain was neutral. That's why it was called the Spanish influenza, because most of the news came from Spain. And you can see that this particular worker is wearing a mask, just like we do now. Malaria. So malaria is actually a little bit of a success story. So we'll go back to H1N1. Somebody's talking about Kansas. So nobody really knows where H1N1, the Spanish flu epidemic, started. There's a couple of hypotheses. One of them is that it started in Kansas. One of them is that it started in northern France. I don't know that we'll ever know. So malaria is really interesting. So malaria is a protist, not a virus. That's correct. It's caused by the protist called Plasmodium. Plasmodium falciparum, yes, is one of 5 different species that causes human malaria. Other animals get malaria. In fact, there was a case of malaria in I think it was a penguin in the Bronx Zoo. But we're talking about people and malaria. Malaria is actually a little bit of a success story. So since the year 2000, the number of malaria cases has actually been cut in half. And what are some of the reasons you think it's been cut in half? Mosquito nets, yes. Use of DDT, so that's a really interesting issue. So DDT was used very, very heavily in the 50s and 60s. If you've ever heard of the book by Rachel Carson called Silent Spring, you'll understand that people became very well aware of the sort of downstream effects of DDT, particularly in thinning the eggs of birds and decimating bird populations and many, many downstream effects. So DDT has been banned in many parts of the world, including the United States. And in places where it wasn't banned, the mosquitoes have become resistant to it, so it doesn't really work anymore anyway. So the reason malaria has been cut in half is the use of insecticide-embedded mosquito nets. So these are mosquito nets, many of which them have an insecticide sort of impregnated in the netting. So one way to look at it is that at the turn of the 20th century, 1 child died about every 15 or 20 seconds from malaria. And so we've halved it. So we have about 1 child dying about once a minute, a little bit, maybe a little bit less than that. So yes, we've halved it to about 450,000 deaths per year, but that's still a lot of patients. So yes, the whole story of sickle cell is very interesting. So sickle cell is retained in our human population because it confers a degree of immunity to malaria. This last picture, does anybody know, can anybody tell me what you think this last picture is? Who knows why only female, wait, we'll go back. I'm loving these questions. Who knows why only female mosquitoes carry malaria? I'm gonna find a question where I'm gonna stump you guys. Oh, that's it, only they bite, exactly. Male mosquitoes, the only point of being a male mosquito is to have sex and die. Female mosquitoes, once they grow up, they have sex, eat blood, lay eggs, then they die. So yeah, so exactly. Oh, wow, Esther, I'm so glad you learned something. Okay. So this is cholera, and we can tell because of this bucket right here. These very unfortunate patients are cholera patients, and these are called cholera cots. So during a cholera epidemic, tents are set up with these cholera cots because patients will lose up to 20 liters of liquid per day, and they are incontinent. Obviously, if you're having that much diarrhea, you can't help it. And so these cots have little holes, cut right where right where your butt cheeks would be, so that it catches the rice water stool. It's called rice water stool because it's not feces anymore. It's just liquid and a little bit of mucus that gets sloughed off at the same time. So patients can very rapidly become dehydrated and die from this. And John Snow, yes, it's a great book on that. The title, but it's by a guy named Stephen Johnson. Ghost Map. Yes, thank you, Raya. I don't know how to say your name. I'm sorry. So yes, Ghost Map is a great book. Highly recommend it. What I thought we would do is we're going to look at 2 videos about the Haitian epidemic. One is from 2010. The second one is from 2015. And then what we're going to do is we're going to talk about how healthcare teams, not just doctors and nurses, what does it take to really understand an epidemic and move us past it. And just FYI, we are currently in what's known as the 7th pandemic of cholera. So there have been 6 previous pandemics, and we are currently in the 7th. So although COVID-19 gets, you know, all the news media about being a pandemic, we have been in the 7th pandemic for quite some time with cholera. So what I'm going to do is I think I have to stop sharing this and bring up my other screen to show you the videos, because I don't think otherwise it will work. Okay, you ready? If this doesn't work, just let me know.
It's working.
4-year-old Ronaldo is one of the over 700,000
Whoops, sorry.
Haitians to contract cholera since the outbreak in 2010. His community's timely intervention allowed him to receive treatment before the illness could claim his life.
Moi j'étais sous marché et puis sem nan li même li vinn côté moi. Pour moi même penser c'est mou pour façon de venir chercher moi.
Since 2010, over 8,000 Haitians have died of cholera. Once infected by this bacterial disease, a person becomes ill with severe vomiting and diarrhea. Immediate action is necessary for an effective response. Ronaldo's aunt had to act fast at the first sign of infection.
Quand y a le fait c'est un moral bali, après ça li menen dans centre choléra gressière. Si mon nan te même getan déshydraté même. Docteur fait me connaît s'il pas de brasser homme nan depuis la caille moi, elle getan arrivé l'hôpital là.
Carlene is one of the 7,000 community members in the Gracier area who have been a part of GOL's cholera prevention interventions with the financial support of Irish Aid and in cooperation with national and international partners.
Les GOL, te connais moi gen ka choléra la caille moi, te venu et puis de bay Clorox et pour désinfecter caille là pour l'autre monde qui pas attraper maladie.
C'est nous, l'équipe de OH Gracier, qui s'en charge. Donc, on fait une partie de sensibilisation pour expliquer aux gens les causes probables de contamination de choléra. On les explique les préventions, les précautions à prendre. On distribue des kits de choléra qui a des sérums oraux, des aquatables, des savons pour le lavage des mains, des aquatables pour le traitement de l'eau de boisson.
Cholera is spread through the feces of contaminated persons to food and water sources. The persistence of cholera in Haiti is mainly due to limited access to clean water and sanitation facilities.
Les gens n'ont pas vraiment accès à la sanitation. Il y a des zones où les gens font leurs besoins et dans les jardins, dans les routes, n'importe où. Le plus souvent, les gens parcourent près d'1 heure de temps pour aller chercher de l'eau. Au cours du programme de GOL financé par Irish Aid, on a réhabilité certains points d'eau dans les communautés afin que la personne puisse collecter de l'eau dans une zone protégée.
In close partnership with affected communities, families, and local authorities, GOL has rehabilitated and constructed over 500 latrines and hand-washing stations, as well as 12 water points to improve access to potable water.
Avant nous te kon boire de l'eau à terre, c'est grâce à l'eau ça qui fait nous pas plus infectés.
Okay, before we start this next one, what I want you to do is, if you have a piece of paper, not in the chat, but if you have a piece of paper handy, I want you to jot down the different types of people that are involved in this report about the cholera epidemic in Haiti, which was from 2010. So I want, because I really want us to be thinking about how all these teams have to work together. So you ready?
Our look at Haiti 1 year after the earthquake. Tonight, a battle against an epidemic unfolding in the countryside and cities. In the village of Sodo, high in Haiti's central plateau, mourners gathered to share their grief over loved ones lost to cholera. A Haitian psychologist working with the aid group Partners in Health had organized this meeting. One by one, people told their stories. The first man described his 5-year-old son, 1 minute playing soccer, and then soon after falling gravely ill. His son, he said, died in his arms. Another man told of losing several family members and friends. He said, "I feel like a bird left without a branch to land on." Even as they spoke, in a tent nearby, the sick were being cared for. This small facility, miles from a major treatment center over bone-crushing dirt roads, has seen about 1,000 people, and at least 30 have died here.
Cholera is breaking people in this area. It's killing us poor people.
Nationwide, in the first outbreak of cholera this country has seen in more than 100 years, there have been some 140,000 cases, with the death toll now well over 3,000. The numbers exploded quickly over just several days, beginning in late October.
That was emblematic of how quickly this overtook kind of the communities and how much our focus had to be shifted away from primary care and other types of care.
Dr. David Walton set up the main Partners in Health Cholera Treatment Center, a makeshift camp of tents just outside the small city of Mirebalais. So has the response that you've seen been adequate?
I would say that there is a strategy in place that I think is a sound strategy of community-based interventions, of treatment centers, of an architecture of a response. The resources and the rapidity of the response has been too slow.
One young man had just been carried into the treatment center. His aunt told me they'd come from a village 10 miles away.
I suspected it could be cholera because this morning the diarrhea took hold of him. We just see the sickness fall upon us, but we don't know how we catch it.
One of the tragedies of the outbreak is that the disease is so easy to treat. Cholera is a bacterial infection that spreads through human waste in contaminated water. Its victims suffer intense diarrhea, a catastrophic flushing out of all fluids that can cause bodily functions to fail within hours. If caught in time, rehydration and antibiotics will save the great majority of people. But so many here live in remote areas far from help. Dr. Hébert Toulousma runs the clinic.
Of the people who live far, far away, we lose many. They end up dying en route or at home because they don't have the means to get to care.
This beautiful region along the Artibonite River is ground zero for an outbreak of cholera. It's brought a new public health emergency to this nation, one still reeling from January's earthquake, and so much more. Nearly 60% of the country's population lives in the countryside in small communities. Life in these rural areas is a daily struggle. Wood and food must be fetched and carried. There's often no electricity, toilets, or access to clean drinking water. The river is a lifeline, used by farmers tilling rice paddies, families bathing, women washing clothes. But all of this is a breeding ground for disease, including cholera.
The person usually comes in and has an upset stomach. They've had diarrhea and the symptoms of cholera.
Nadia Guerrier is a young volunteer working with the aid group Oxfam. At her tiny way station by the river, she showed me how she mixes a chlorinated solution of drinking water for villagers. In Casite, where she lives, Oxfam is working with locals to get out the word about preventing the disease. They test water for contamination, offer purification tablets, and explain that the chlorine taste, while not to the villagers' liking, is necessary. New latrines have been built that can be shared and last many years. The message, carried by a local community leader and an aid worker, is simple, if not always easy to follow in practice. Drink only treated water, wash your hands, and use the latrines.
I come around every 3 days to get the word out and help people understand that cholera can kill them very easily.
The emphasis is to make sure that the personal hygiene is the most important thing to prevent cholera.
Such messages are now everywhere around the country. While cholera began in the countryside, a great fear has been that it will sweep the overcrowded city as well into places like this. La Saline is one of Port-au-Prince's notorious slums. This is a kind of unofficial community of thousands who live without municipal services. Conditions here are dreadful, with fields and ditches of human waste and garbage.
Epidemiologically, this area is terrifying. You've got salt, you've got feces everywhere, you don't have much municipal water service, so it's a tremendous concern. This is an area where we would expect to see potentially really dangerous levels of transmission.
Ivan Gayton, with Doctors Without Borders, took us to a makeshift reservoir, a small basin of water from a broken pipe on this area's one paved road. Residents, mostly women and children, gather here all day long to fill their plastic buckets. Volunteers for the aid group offer purification drops, a quick squirt for anyone who wants it.
Before, the water was no good. It had many diseases, but now it's okay.
How do you get the word out to people?
No need. We just set up here, and there's already people coming to this unofficial water point. All we do is sit here with our chlorination. People really know that there's a problem, and they know that they need something. So they're actually quite eager.
And there are signs of progress. Gayton says there's been as many as 500 cases in this area, but the number has fallen recently. A giant slum, makeshift approaches, but this qualifies as a success story in the cholera fight. The risk for infection in the tent communities that dot the city is actually not as high, because international organizations like the Red Cross provide sanitation services and fresh water daily. But even as aid groups try to head off the epidemic, questions remain. How did this outbreak happen? Why now, amid the massive humanitarian relief effort after the earthquake? The immediate focus has been here, a UN base manned by peacekeepers from Nepal, a tributary of the Artibonite River. The UN first denied its soldiers had channeled their waste into the river. Subsequently, the strain of cholera now in Haiti was determined to be one predominant in Asia. And after much criticism, the UN has just named a panel to investigate. Nigel Fisher is the UN's humanitarian coordinator in Haiti.
We've had a number of epidemiologists here with different viewpoints. One from France saying, yes, it looks like it has to be the Nepalese. Others saying, no, we don't think it was, you can pinpoint those. Others saying it's a climatic factor. So I hope this independent commission can at least start to really dig in and come up with a point. In retrospect, yeah, maybe we should have had the commission much sooner.
Whatever the results, everyone we talked with reminded us that disease in Haiti is a longer-term problem, one that predates the earthquake and ultimately relies on building a proper water and sanitation infrastructure. The Haitian government has a proposal to make a start at that as a part of the larger reconstruction plan. It's awaiting funding. For now, the hope is to contain the cholera outbreak in Haiti. There are some signs it may have peaked in certain areas, even as it spreads to new ones. From the city to the countryside, health experts say cholera may well be here to stay, endemic to Haiti. Another disease of poverty in this nation struggling to survive.
No.
October 2010.
Hang on. Why
The
is that
hospital
doing
in a
that?
small
Hang on.
rural town north of the capital. These were the first victims of a horrific unknown disease in a country still reeling from a devastating earthquake. Patients were dying in the space of a few hours.
Sorry about that. Let me go back. Okay. So, and let me bring up the chat again. So yes, it was the Nepalese. That's the punchline there. Does anybody know when the cholera epidemic in Haiti was finally declared over? So it started in January 2010. Yeah, 2019 actually. So they had it for a whole decade. About 665,000 people were infected and over 8,100 people died. So it was really a long, horrible march, so to speak. So now I gave you a little bit of homework to do while we were doing that. So I want to see in the chat, which is actually a little terrifying to watch. There you go. Medical anthropologists, psychologists, doctors, nurses, educators, community health workers, Oxfam volunteers, peer educators, volunteers, translators, NGOs, Irish Aid, Oxfam. So those are all the NGOs, non-governmental organizations, public health professionals, nurses, interpreters. Very good. Whoa, you guys are great. Red Cross, contact tracer. Yeah. So community members, Nigel Fisher. So great. So I tried to sort of organize it on the next slide. Partners in Health. So Partners in Health is a great organization. If you, there's a good book called From Mountains to Mountains, or it's by Paul Farmer. You should read it. Just look up Paul Farmer. Anyway, so Mountains Beyond Mountains. Thank you, Ruhi. You guys are so smart. I can't stand it. It's great. Okay, so I tried to organize it. So we have obviously doctors, nurses, psychologists, people who are giving direct care. People have to develop the drugs. There is actually a vaccine for cholera. It is not very effective. It only lasts about 6 months. It's used primarily in for travelers, and it's used in if there's an outbreak that begins, say, in a refugee camp or something like that. It's an oral vaccine. Yes, it's an oral vaccine. Why does it make sense that it's an oral vaccine? You get you take it twice, but it doesn't last for very long. It'll get you through an outbreak. Yeah, it goes to your gut. So you want to stimulate those immune cells in your gut to produce antibody against the Vibrio cholera bacteria. So here we have disease physiologists. So you need GI people who understand the GI tract, people who understand immunology. You need people who understand the organism, so that you know what kind of drugs to take, so that you know how to control Vibrio cholera in the environment. Vibrio cholera normally lives, anybody know where Vibrio cholera normally lives? It's not inside people. Where does it normally live? Food and water. Yeah, it actually lives, it's actually sort of interesting. It lives on the surface of like little brine shrimp. Yes, shellfish, because it has a special enzyme that breaks down chitin, which is the, have you ever shelled shrimp and you know the little exoskeleton? So it breaks down the that big carbon molecule and eats that. So public health, you guys definitely hit on the epidemiologist, tracking, tracing, tracking, education, infrastructure, water sanitation, and latrines. So now, what time is it? We have, okay, 11:44. So for our last thing, what I want you to do is I want you to pick one of these, just one. There's like 10,000 of you, so I'm sure they'll all get covered. And I want you to think of one question. If you were working in Haiti, one question you would need answered before you joined one of these teams. So think, and post your question. Don't be shy. We're not, nobody knows, we can't see you, so no peer pressure at all. So think about a question you would need answered if you were in Haiti to really make a difference in an epidemic, in the cholera epidemic. What kind of questions you would want? And actually, when you type your question, sort of put before like infrastructure : education : tracking : so that I can sort of pick ones All right. So I'm going to start going through these. You guys can keep putting them up. All right. Why is it, well, but going back to this, why is it important to receive a second dose of oral vaccine? Because you don't get a strong enough immune response the first time. You need to sort of tickle the immune system. It's a little bit more complicated than that, but you need to re-stimulate the immune system to get even the modestly enduring immune response. How do we make resources available to all those remote areas? So that would be, I think, infrastructure. This is a perfect example. I mentioned that during the smallpox eradication campaign, they used motorcycles because they realized that cars or vans or whatever wasn't going to give people the kind of mobility that they needed. Where is the outbreak contained, and how and where can it spread? Right. So you're going to be looking at all the sewers. You're going to be looking at all the rivers. So you're going to be looking at basically all the water. Improving existing infrastructure. So what's really interesting is if you provide clean water and sewage to people, that is to a community, that is going to give them the biggest, it's going to have the biggest impact in their sort of GDP or their ability to make money. It's also going to have the biggest impact in longevity or lifespan. Bigger than vaccines, bigger than antibiotics. Clean water and proper sewage is sort of ground zero. Is there community trust in these NGOs? So that's why you have to read Paul Farmer's book. So there's a very big NGO called Partners in Health that's been based in Haiti for many, many years. It was there for at least 15 years before the earthquake struck, which was really a good thing. Mechanism and transmission, how is it known? Who is patient zero? So patient zero is the first case. And I'm going to jump down here. Why is it important to know? I never want to ask. I'll get too many responses. Why is it important to know who patient zero is? Because then you can start tracing the spread of it. What percent of the population is impoverished? Unfortunately, in Haiti, it's the vast majority. So the vast majority of people are at risk. Education, what is the literacy rate? That's super, super, Alyssa, I give you hats off. I give you a lot of credit. That's a great question because you have to tailor your education campaign to the people on the ground, not to the people you just left in the United States. What supplies do we have and can we get? So this is always an issue with these kinds of situations because all these tents and drugs cost money. Exactly. So Alexandra, you're on the same wavelength as Alyssa. So is there a lot that can be done in terms of medical intervention? It's just making people comfortable. So medical intervention is really an electrolytes IV solution. Sometimes antibiotics are given, but in most cases, you don't even have to give antibiotics. So it's really just keeping people hydrated. You can imagine if you're flushing 20 liters a day through your GI tract, you're getting rid of that bug. So it's just making sure people don't die of dehydration during the height of the symptoms. In what environments does this microorganism thrive? So Vibrio thrives in any kind of water. So freshwater, saltwater. So are there other viral infections? Vibrio cholera is a bacterium, but yes, you're always going to be looking for other what we call super infections or other infections that are going on in the community. You know, it's sort of like with COVID, right? People stopped going to the doctor, or every time people sneezed, they thought they had COVID. There are still other things circulating. How do we further educate? So education is huge because people have to know to use latrines properly and to clean their water, and then that puts them, it minimizes risk. Just like we're wearing masks and doing social distancing to minimize risk. Is there enough medication available for everybody? And that's really a matter of money and resources. What are the pathophysiological alterations caused by the disease? That's a really great question. And so there are microbiologists that are looking at it from the point of view of the microbe. So what does the bacterium do to the host, right? And then how does the host respond to the presence of the bacterium? So for all of these infectious diseases, whether it's malaria caused by a protozoan, cholera caused by a bacterium, chickenpox, or any viral disease, there's always this sort of yin and yang of the microbe doing something to the host doing something back, and what happens in that interaction. You can't just be super focused on one and not the other. So the whole issue with the Nepalese UN troops was rather poorly handled by the UN, but eventually they did own up to it. Is it self-sustainable after aid is provided? Yeah, that's one of the big criticisms of these kinds of aid groups that sort of helicopter in, do their good deeds, and then helicopter out, is that it's great while they're there, but they don't stay long enough to make a lasting impact. So how many filtered water sources can sustain a given community? Yeah, so if you're going to start enacting these kinds of activities, then you need to understand how it's going to be impacted. So here we have our medical intervention. This is a solar-powered water filtration. So getting to your issue of sustainability, this is something that people could come in, set up, and it would be maintained. It would be sustainable. Here is sort of point of view of the microbe, point of view of the host, and here is a poster about cholera. So it's 11:53. Let me just see if there's any last burning questions. Tracking. Yeah. You guys are really on top of it. How do we create a universal education plan to ensure everyone is receiving the necessary information? Exactly. So you guys all have brilliant careers waiting for you in public health. I can see that. Can someone catch the disease more than once? There are different strains, if you will, they call them biotypes of cholera. You have lasting immunity to the one type, but not the other. So it's I think if you're sitting on one of those cholera cots, the second time around, the fact that you're infected by a different biotype isn't really much comfort. What's the infectious period of cholera? What's the incubation period of cholera? It's quite rapid, couple days. Okay, so I think last but not least, we talked about all these different types of people involved, and I know that this is a mixed group. Some of you are undergrads, some of you are already in med school, but if we think about your future and what you're going to do, I think these slides will probably be made available, I'm not sure, but this is just sort of what it takes to become a nurse, a physician assistant, a psychologist. So a psychologist is, so I think a nurse, you guys probably know this, and physician assistant, I'm not going to read the slide to you. A psychologist is sort of interesting because you can do it with a master's degree or you can do it with a PhD in clinical psychology. Physician, you guys probably already are familiar with what that takes. Then there's these other specialty careers like PT, OT, public health worker. So those of you who found these videos quite compelling, you might think about doing an MPH. There are a lot of physicians who go ahead and get an MPH as well as their MD or DO. It requires it's a 2 years master's degree program. And then of course, careers in biomedical research. So there's sort of, you can do it right out of college, right? So that's with a BA or a BS. A lot of people do this for a year or two before they start medical school. You can be a lab manager, which is a more of a career, so that you're managing all the people, the grad students and the postdocs and the medical students in the lab. And that requires a master's degree plus some experience, or you can be what we call a PI, or a principal investigator. So this is the person who's running the study. So this could be a PhD or an MD or an MD PhD. But just for a PhD, I just put it on here just for a PhD so you can see what a PhD entails. So I think that's all I've got. I wanted to leave some time for additional questions. So I will, do you have to do a residency in every country? I think residency, you just do I'm not quite sure what the question is, but usually you do a residency in the country where you went to medical school in. So if you went to a US medical school, you'll do a residency in the field that's of interest to you. So, so for instance, you're going to do a residency in internal medicine, and then let's say you decide to become an infectious disease doctor. That's a subdiscipline of internal medicine. So then you would do a fellowship, which would be an additional year after your residency in internal medicine. Is there a medicinal chemistry application as a career? Oh, absolutely. I actually spent a big chunk of my career doing peptide design in antibiotic drug discovery. So yes, medicinal chemistry is a huge, it's a great career. I highly endorse it. You would get a PhD in chemistry or biochemistry. What are the residency directors looking for now that STEP is pass-fail? So first of all, it's going to take a little while for that to actually hit the residency directors, right? Because it's not pass-fail this year. It won't be pass-fail until 2022. So there's going to be quite a few classes going through. They may be looking at the score on the step 2 medical knowledge. The resident directors are not thrilled about the whole loss of step going pass-fail. But right now we're assuming that the step 2 medical clinical knowledge CK exam is going to sort of take the place. If you're really interested in the cultural effects and how medicine interacts with culture, especially in epidemics, medical anthropology is also really interesting. Avneet, I think you are absolutely right. Can you be PhD physician for infectious disease? Yepers. That would be an MD PhD. Yep. So you apply to an MD PhD program, which means you do your MD with the MD. You get your MD with the MD class, and you do usually 3 years of research. And if you're really interested in infectious disease, you would do your research in infectious disease. What opportunities do MPH grads have that MD grads may not? I don't think I'm not sure that it's so much the opportunities, other than the fact that you have this arsenal of knowledge that opens doors for you. So if you want to study, if you want to do clinical research in infectious disease or epidemiology, it doesn't have to be infectious disease, just things like the epidemiology of cardiovascular disease or smoking, or you have a really good background in that, in the skill set that you need to do that kind of research. So it really opens those doors for you. Medical sociology, yep. Do you find the biomedical field is quite male dominated? I would say not as much as it used to be. Right now, entry level, it's about 50-50 men and women. Excuse me, at the top, at the upper echelons, it's still very male dominated. So Zia, all I can say is we got to keep pushing and keep, breaking glass ceilings. Is it possible to go to medical school in the US and do residency in Canada? Yes. And vice versa. Can you do medical public? I mean, there's all kinds of visa issues and it's sticky. And if you wanted, you should probably do both in the same country. Can you do public health work if you have a master's in public policy? Absolutely. Advice for non-traditional students looking for pre-med program with a non-science bachelor's. I'm trying to find a lab coordinator, basic lab position I can start having completed with only a few prerequisites. Rebecca, that's going to be tough right now because of the unemployment situation and labs being shut down. Non-science bachelor. Rebecca, get my email and email me. MD versus DO, is it harder to match in competitive specialty? Depends on the, I mean, the baseline is yes, it can be. It really depends on those scores. The thing is, I don't know what's going to happen after the step 1 goes away in terms of MD versus DO. Some parts of the country are kind of blind to the MD-DO, other parts of the country not so much. For a student with a 3-4, would you recommend they take a gap year to acquire more experience? It depends on what your other experiences are, what school you went to, and what your MCAT score is. The Dean of Admissions is going to come and talk. Is it time?
Yeah, so
12:02. Okay. So I'm sorry I can't answer all these questions. Lisa, thank you for answering somebody's question. Do you think it's harder applying to med school if you are in your 40s? We have had, at Zucker School of Medicine, we've had several students in their 40s. Yes, it is harder. Many schools will not accept you. Some schools will. Do your homework and find out where people in their 40s have been accepted. Okay. Can you become a PA? Can an MD become a PI without a PhD? Yes, absolutely. I guess we're done.
Thank you so much for speaking. That was great.
Yeah, I'm sorry I wasn't able to answer all these millions of questions.
Yeah, it's hard. They come in a lot, but it was a great presentation. Thank you so much.
Sure. And I'm going to stop sharing. And so, so are the students still on, or did they?
I'm going to end the seminar now. Thank you guys for coming. We'll see you all tomorrow. Have a good day.
Bye-bye, guys.